Linda Peterson here, talking to you about the Heart and Peripheral Vascular System, Chapter 12. Here's your objectives for the PowerPoint. The cardiovascular and peripheral vascular system. So the cardiovascular system is responsible for perfusion. There are mechanisms that facilitate and impair perfusion of oxygenated blood. All tissues require perfusion of oxygenated blood, and all of these physiologic concepts are interrelated. The cardiovascular system transports oxygen, nutrients, and other substances to body tissues. It carries metabolic waste products to kidneys and the lungs, and this dynamic system is able to adjust to changing demands for blood by constricting or dilating blood vessels and altering cardiac output. Remember, the heart is a pump. It beats 60 to 100 times per minute without rest, and it responds to external and internal demands. For the peripheral vascular system, we have arteries, capillaries, and veins, and they provide blood flow to and from tissues. Tough and tensile arteries, their smaller branches, arterioles, are subjected to remarkable pressure generated from myocardial contraction. They maintain blood pressure by constricting or dilating in response to stimuli. The more passive veins and smaller branches, venules, are less sturdy, but more expansible, enabling them to act as a reservoir for extra blood, if needed, to decrease workload on the heart. Pressure within the veins is low compared with arterial circulation. Valves in each vein keep blood flowing in a forward direction toward the heart. The vascular system consists of vessels of the body. Vessels are tubes for transporting fluids such as blood or lymph. Any disease in the vascular system creates problems with delivery of oxygen and nutrients to tissues or elimination of waste products from cellular metabolism. The lymphatics form a completely separate vessel system which retrieves excess fluid from tissue spaces and returns it to the bloodstream. The major artery supplying the arm is the brachial artery, which surfaces at the AC. Immediately below the elbow, the brachial artery bifurcates into the ulnar and radial arteries. The radial pulse lies just medial to the radius at the wrist. The ulnar artery is in the same relation to the ulna, but it is deeper and often difficult to palpate. Major arteries to the leg is the femoral artery, which passes under the inguinal ligament. The femoral artery travels down to the lower thigh where it courses posteriorly, then is termed the popliteal artery. Below the knee, popliteal artery divides, anterior tibial artery travels down front of the leg onto the dorsum of the foot where it becomes the dorsalis pedis. In the back of the leg, the posterior tibial artery travels down behind the medial malleus and in front and forms the plantar arteries. Peripheral artery disease affects non-coronary vessels and refers to arteries affecting the limbs. Course of veins parallel that of arteries. The body has more veins and they lie closer to the skin surface. The legs have three types of veins. Deep veins, which run alongside deep arteries and conduct most of venous return from the legs. Superficial veins are great and small, such as the saphenous vein. Perforators are connecting veins that join two sets of veins, drain deoxygenated blood and its waste product from tissues and return it to the heart. Dilated and tortuous, also known as varicose veins, create incompetent valves, leading to increased venous pressure which further dilates the vein. Some of the questions you would ask regarding complications with the peripheral vascular system would include, do you have any leg pain or cramps? If so, where? Describe the type of pain. Is it burning, aching, cramping, or stabbing? Did this come on gradually or suddenly? Is it aggravated by activity or walking, or is it worse at rest? How many blocks or stairs does it take to produce this pain? Has this amount changed recently? Is it worse with elevation or cool temperature? Does it wake you up at night? Have you had any recent change in exercise? What do you do to relieve the pain? Do you dangle your legs, walk? Do you rub them? Is a leg associated with any skin changes? Do you have any history of vascular problems, heart problems, diabetes, obesity, pregnancy, smoking, trauma, prolonged standing, or bed rest? Any skin changes in the arms or legs? If so, what color? Is it red? Are they pale? Are they blue? Are they brown? Any change in temperature, excess warmth or coolness? Do your leg veins look bulging and crooked? Do you use support hose? Any leg sores or ulcers? Swelling in one or both of the legs? What time of day is swelling at its worst? Is it in the morning, all day, or at the end of the day? Does the swelling come and go, or is it constant? What seems to bring it on? Is it standing all day? Is it sitting? What relieves the swelling? Elevation, support hose? Is swelling associated with pain, heat, redness, ulceration, or hardened skin? Do you have any swollen glands? Where in the body and how long have you had them? Any recent change? How do they feel to you, hard or soft? Are they painful? What medications are you taking? For example, oral contraceptives, hormone replacement. And do you smoke? If so, how many packs per day and what age did you start? Check their capillary refill. As we know, cap refill should be 1 to 2 seconds or less, and that is considered normal. Pulse assessments. The radial pulse, always compare pulse points bilaterally and simultaneously, so compare the right with the left. You're going to palpate both radial pulses, noting the rate, rhythm, elasticity of the vessel wall, and equal force. Grade the force by amplitude on a 3-point scale. A 3+ is an increased full bounding pulse. A 2+ is normal, a 1+ is weak, a 0 is absent. Palpate the brachial pulses. Their force should be equal bilaterally. Inspect and palpate the legs. Uncover the legs while keeping the rest of the patient draped. If the lower legs look asymmetric, measure the legs at the widest point, taking care to measure the other leg in exactly the same place, same number of centimeters down from the patella or another landmark. In presence of skin discoloration, skin ulcers, or gangrene, note size and exact location. Palpate for temperature along legs down to feet, comparing symmetric spots. Locate for more arteries just below the inguinal ligament, halfway between the pubis and the anterior superior iliac spines. Press firmly, then slowly release, noting pulse tap under your fingertips. If the pulse is weak or diminished, auscultate site for a bruit. For the popliteal pulse, with the leg extended but relaxed, anchor your thumbs on the knee and curl your fingers around into the popliteal fossa. Press your fingers forward hard to compress artery against the bone, and often it's just lateral to the medial tendon. Often a normal popliteal pulse is difficult to palpate. For the posterior tibial pulse, curve your fingers around the medial malleus. Feel the tapping right behind it in the groove between the malleus and Achilles tendon. For the discalis pedis pulse, it only requires a very light touch, normally just lateral to and parallel with extensor tendon of the big toe. Be sure not to mistake pulses for your own pulse in your fingertips. In adults over 45, occasionally either the dorsalis pedis or posterior tibial pulse may be hard to find, but not both on the same foot. Question. During the examination of the lower extremities, you are unable to palpate the popliteal pulse. What do you do next? Do you proceed with the examination? Do you refer the patient to a vascular surgeon for further evaluation? Do you schedule the patient for a venogram? Or do you schedule the patient for an arteriogram? That should be number D. Based on what we just said, it should be A. You proceed. You're not expected to always find the popliteal pulse. The lymph system works in collaboration with the peripheral vascular system in removing fluid from interstitial spaces. As blood flows from arterioles into venules, oxygen and nutrient-rich fluid is forced out of arterial end of capillary into interstitial space and then into cells. Waste products from cells flow through interstitial spaces to venous system to the end of the capillaries. Excess fluid left in the interstitial spaces is absorbed by the lymph system and carried to lymph nodes throughout the body. Lymphatic fluid is normally clear. It's composed mainly of water and protein, mostly albumin. The lymph nodes are tiny oval clumps of lymphatic tissue, usually located in groups along blood vessels. The lymphatics form a completely separate vessel system, which retrieves excess fluid from the tissue spaces and returns it to the bloodstream. The functions of the lymphatic system are to conserve fluid and plasma proteins that leak out of capillaries, to form a major part of the immune system that defends the body against disease, and to absorb liquids from the intestinal tract. Superficial groups of nodes are accessible to inspection and palpation, giving clues to status of the lymphatic system. The lymphatic system has the same function in children as in adults. Lymphoid tissue has a unique growth pattern compared with other body systems. It is well developed at birth and grows rapidly until about age 10 or 11. The lymph nodes are relatively large in children. The superficial nodes are often palpable even when the child is healthy. With infection, excessive swelling and hyperplasia can occur. For pregnant women, hormonal changes cause vasodilation and a resulting drop in blood pressure. This is from the growing uterus, which obstructs drainage of the iliac veins and inferior vena cava, and this condition causes low blood flow and increases venous pressure. This in turn causes dependent edema, varicosities in legs and vulva, and hemorrhoids. For the aging adult, peripheral blood vessels grow more rigid with age, resulting in a condition called arteriosclerosis. Care for myocardial infarction now includes early mobilization and low-dose anticoagulation medication, which reduce the risk of pulmonary embolism. Loss of lymphatic tissue leads to fewer numbers of lymph nodes in older people and to decrease in size of the remaining nodes. Lymphedema. It is common after damage to lymph nodes in the axillary regions after radiation. The patient will complain of a heavy arm, their jewelry will be tight, there's unilateral swelling, so it's just one arm, and non-pitting edema. The treatment for the arm is exercises and wrapping in compression garments. Typically we use, it's similar to a TED hose, it's just on the arm. You'll see many breast cancer patients who experience lymphedema. Avoid this arm for blood pressures and lab draws. Allen's test. It's used to evaluate collateral circulation prior to cannulating the radial artery. This is when we're going to put in an art line. Firmly occlude both ulnar and radial arteries of one hand while the patient makes a fist several times. This causes the hand to blanch. Ask the patient to open their hand without hyperextending it, then release pressure on the ulnar artery while maintaining pressure on the radial artery. Adequate circulation is suggested by a return to hand's normal color in approximately 2 to 5 seconds. The ankle brachial index, ABI. The ABI is a highly specific, non-invasive, and readily available way to determine the extent of peripheral arterial disease. Specific criteria for the procedure includes the patient lying flat and heels fully supported with correct choice of cuff size. No smoking within 2 hours with 5 to 10 minute rest period prior to measurement. 2 measurements are taken and then the average is used as the recorded pressure. The formula calculation required. Divide the systolic pressure from the leg by the brachial systolic pressure, ankle brachial, to calculate the ABI. An ABI between 0.91 to 1 is borderline. 0.90 or less is PAD. 0.40 or 0.3 is severe. Less than 0.3 is ischemia with impending loss of tissue. Pitting edema. Firmly depress the skin over the tibia or the medial malleus for 5 seconds and release. Normally your fingers should leave no indentation, although a pit commonly is seen in persons who have been standing all day or during pregnancy. If pitting edema is present, grade it on the following scale. 1+, mild pitting, slight indentation, no perceptible swelling. 2+, moderate pitting, indentation subsides rapidly, such as rebounds in just a few seconds. 3+, deep pitting, indentation remains, leg looks swollen, greater than 10 to 20 seconds. 4+, very deep pitting, indentation lasts a long time, the leg is very swollen, and it lasts greater than 30 seconds. The scale is subjective and qualitative. The amount of pressure used is arbitrary, as is judgment of depth and rate of pitting. Clinicians need a standard quantified scale to ensure consistent clinical measurements and management. Many classify the edema by measuring the depth of the pitting in centimeters. Some measure with a millimeter scale, others by an increase in weight. Still others try to quantify rate of time pitting remains after release of pressure. Check with your institution to determine a consistently used scale. Raynaud's is a vasospasm of the arterioles and arteries of the upper and lower extremities. The vasospasm causes constriction of cutaneous vessels. Blanching of the extremity followed by cyanosis may occur during vasospasm. When circulation returns, the extremity will be rubor in color. Numbness, tingling, swelling, cold temp all affect that body part that has the Raynaud's phenomenon. The treatment includes vasodilators and keeping warm, such as wearing warm clothing, gloves, and avoiding extreme temperatures. Always identify your precipitating factors. Typically cold weather is one of them. So, which clinical manifestations are seen in patients with Raynaud's phenomenon? Select all that apply. Intermittent fevers, sensitivity to cold temperatures, gangrenous ulcers on fingertips, color changes of fingers and toes, episodes of superficial vein thrombosis. Well, as we just discussed in the last slide, it would be B and D. So peripheral artery disease, also known as PAD, involves progressive narrowing and degeneration of the arteries of the upper and lower extremities. Atherosclerosis is the leading cause in the majority of cases and typically appears in ages 60s to 80s. Goes largely undiagnosed. Risk factors are cigarette smoking, hyperlipidemia, hypertension, diabetes. The femoral popliteal area is the most common site in non-diabetic patients. The patient with diabetes tends to develop PAD in the arteries below the knee. In advanced PAD, multiple levels of occlusions are found. Classic symptoms of PAD is intermittent claudication. They will have ischemic muscle pain that is caused by a constant level of exercise. It resolves within 10 minutes or less with rest. It is reproducible. Paresthesia results from nerve tissue ischemia. True peripheral neuropathy occurs more often in patients with diabetes and in those with long-standing ischemia. Neuropathy produces severe shooting or burning pain in the extremity. Gradual reduced blood flow to neurons produces loss of both pressure and deep pain sensations. Thus, patients may not notice lower extremity injuries. The assessment, you will see thin, shiny, and taut skin, loss of hair on the lower legs, diminished or absent pedal popliteal or femoral pulses, pallor of the foot with leg elevation, reactive hyperemia of the foot with dependent position. They will complain of pain at rest. Patients often try to achieve pain relief by dangling the leg over the side of the bed or sleeping in a chair to allow gravity to maximize blood flow. A supervised PAD rehab program is an effective means of improving exercise performance. Such programs typically include exercise for 30 to 60 minutes a day for 3 to 6 months. Supervised treadmill exercises training improves walking performance and quality of life in PAD patients, whether or not they have claudication. Why does pain occur at rest in PAD? It is due to inadequate blood supply to the muscles. So, vasospasm of small cutaneous arteries in the feet? No. Increase in retrograde venous blood flow of the legs? Nope. Decrease in arterial blood flow to the nerves of the feet? Nope. Decrease in arterial blood flow to the leg muscles during exercise? It would be D. Rest pain is severe pain which occurs in the lower legs when blocked arteries do not allow enough blood flow and oxygen supply to the legs. This pain occurs even when at rest. PAD mainly presents as change in skin color of the affected limb, pain in limbs when walking, and weakness in legs. Lifestyle changes are the first line of treatment, and this is followed by medications and surgery. Chronic venous insufficiency. It's a condition that occurs when the venous wall and/or valves in the leg veins are not working effectively, making it difficult for blood to return to the heart from the legs. CVI causes blood to pool or collect in these veins, and this pooling is called stasis. Calf muscles and the muscles in the feet need to contract with each step to squeeze the veins and push the blood upward. To keep the blood flowing up and not back down, the veins contain one-way valves. When CVI occurs, these valves become damaged, allowing the blood to leak backward. Valve damage may occur as a result of aging, extended sitting or standing, or a combination of aging and reduced mobility. When the veins and valves are weakened to the point where it is difficult for the blood to flow up to the heart, blood pressure in the veins stays elevated for long periods of time, leading to CVI. Most commonly occurs as a result of a blood clot in the deep veins of the legs, a disease known as deep vein thrombosis, DVT. It also results from pelvic tumors and vascular malformations, and sometimes occurs for unknown reasons. Failure of the valves in the leg veins to hold blood against gravity leads to sluggish movement of blood out of the veins, resulting in swollen legs. CVI that develops as a result of DVT is also known as post-thrombotic syndrome. As many as 30% of people with DVT will develop this problem within 10 years after diagnosis. What is a priority nursing intervention in the care of a patient with a diagnosis of CVI? Is it application of topical antibiotics to venous ulcers, maintaining the patient's leg in a dependent position, administration of oral and/or subcutaneous anticoagulants, or teaching the patient the correct use of compression stockings? In this case, it would be D. Deep vein thrombosis, or DVT, is a blood clot that forms in a vein deep in the body. Most deep vein clots occur in the lower leg or thigh. If the vein swells, the condition is called thrombophlebitis. A deep vein thrombosis can break loose and cause a serious problem in the lung called a pulmonary embolism. Signs and symptoms: onset, intense, sharp pain, warmth, swelling, redness around the site, usually the leg. For thrombosis, sometimes recognized by dilated superficial veins, edema, and redness of the involved extremity, and increased circumference of the involved leg. In upper extremity, venous thrombosis and thrombophlebitis may occur in superficial veins and are recognized by redness, warmth, and tenderness over the affected area. Veins may be visible and palpable. What are probable clinical findings in a person with an acute lower extremity DVT? Select all that apply. Pallor and coolness of foot and calf, mild to moderate calf pain and tenderness, grossly diminished or absent pedal pulses, unilateral edema and induration of the thigh, palpable cord along a superficial varicose vein. Based on what we discussed, it would be B and D. Whoopsie! What I forgot to say, if you have a larger aneurysm, so it's greater than 5 centimeters, that is a risk for rupture. So then it has to be surgically repaired. Usually we go in through the femoral artery and do a prosthetic graft that covers that area that has the weakened vessel, and that usually works just fine. Most patients stay in the hospital for a few days. Recovery time can take a few months. Heart failure. Heart failure occurs when either ventricle fails to pump efficiently into the aorta or pulmonary arteries. Heart failure may occur in the left or right ventricle or both. Because the left ventricle cannot pump sufficient blood forward, some blood backs up into the left atrium and eventually into the pulmonary capillaries, causing pulmonary congestion. So left, we always think lungs, pulmonary congestion. Right-sided heart failure occurs when the right ventricle has difficulty pumping blood to your lungs. Blood backs up into the blood vessels, which causes fluid retention in your lower extremities, abdomen, and other vital organs. FACES is a common acronym used for heart failure. F for fatigue, A for limitation of activities, C for chest congestion or cough, E for edema, and S for shortness of breath. Here are mnemonics for the left and right-sided heart failure. Left side heart failure symptoms include paroxysmal nocturnal dyspnea. This happens when the patient awakes in a panic, has feelings of suffocation, and a strong desire to sit or stand up. It's caused by the reabsorption of fluid from dependent body areas when the patient lies flat. They will also have orthopnea, dyspnea, tachycardia, fatigue, cyanosis, cough, crackles, wheezes, and tachypnea. Right-sided heart failure symptoms include fatigue, an S3 murmur, ascites, JVD, anorexia with GI upset, and dependent pitting edema. Subjective questions would be, do they feel fatigued or depressed? Are they anxious? What is their usual sodium intake? Have they any nausea, vomiting, or anorexia? Any complaints of stomach bloating or weight gain? Do they have ankle swelling? How many pillows do they use for sleeping? Do they wake up in the middle of the night feeling suffocated? Do they sleep through the night? Do they have any chest pain or heaviness? Right upper quadrant pain or abdominal discomfort, behavioral changes, or visual changes? Objective data, you'll see skin color and temperature changes, edema, respiratory rate, and sounds. The respiratory rate will be elevated. The sounds, you could have wet lung sounds. You may see frothy blood-tinged sputum, which is usually pulmonary edema. Heart rate and sounds will be louder and sometimes muffled. Abdominal distension and sometimes changes in LOC. Pericarditis is inflammation of the parietal and visceral layers of the pericardium and outer myocardium. It may be idiopathic or the result of myocardial infarction, uremia, cancer, trauma, infections, cardiac surgery, or autoimmune reaction. Two classic findings are pericardial friction rub and chest pain. The pericardial friction rub develops as inflamed layers of the pericardium move against each other. The friction rub is best heard with the patient leaning forward so that the heart is closer to the chest wall. Listen in the second, third, or fourth intercostal spaces at the left sternal border or at the apex. It is louder on inspiration. The pain is described as sharp, pleuritic pain aggravated by deep breathing, lying supine, or coughing. Treatment for acute pericarditis may include medication for pain and inflammation, such as ibuprofen and aspirin. Depending on the cause of the pericarditis, they may need antibiotic or antifungal medication. That is it for this one. Have a good day. Thanks very much. Bye-bye.